My name is Dr. Muhammad Bayat. I'm an interventional radiologist at Smit and Partners. I work as an associate radiologist. My main focus is interventional radiology, but I also do other forms of radiology as well. So basically, uterine fibroid or uterine artery embolization is a minimally invasive way of treating uterine fibroids, which are abnormal but non-cancerous growths in the uterus. And the advantage of uterine fibroid embolization is that it's minimally invasive. Patients come in the morning of the procedure, we do the procedure, they usually stay overnight, and they're back home the next morning and usually back at work within a few days. The flip side is doing open surgery. It's a lot longer, the recovery is a lot longer, and there's a lot more pain involved. Most of our uterine fibroid cases are relatively straightforward and go very well, but every now and then we do get the odd complex case. The ones that really come to mind are the younger patients who wish to fall pregnant after the procedure. They've been trying for a while, and perhaps the fibroids are the reason they're not able to fall pregnant. So in those cases specifically, we make sure that we counsel the patients and let them know that although fibroid embolization will give them a chance to fall pregnant, it may not. And we've had multiple successes doing uterine fibroid embolizations in patients with no hope and them falling pregnant afterwards and getting a beautiful young child. Radial access or radial approach has been a game changer in how we treat uterine fibroid embolization. Traditionally, uterine fibroid embolization was performed by placing a small catheter or tube into an artery in the groin and passing that into the fibroids or the uterus and injecting the material to block the fibroids, block the blood supply, starve them of nutrition and causing them to shrink. Now we're doing them from a small artery in the wrist. Once we're done, the patient gets a little band that compresses the artery, and they're able to move around, they're able to eat, they're able to use their cell phone. Previously, they would have to stay in bed for at least 6 hours, absolutely flat, absolutely still, not able to eat, not able to go to the bathroom. So for me, that's been a true game changer in how we do it and how patients recover. There's multiple ways of doing things. There's multiple ways of getting the patient better. And at the end of the day, we have to decide what's best for this particular patient. What may work for this patient may not work for another patient. So when we are referred patients from doctors for uterine fibroid embolization, we will often sit the patient down, discuss the case, and if needs be, chat with the referring doctor to see if this is something that is the best management for this patient. And so we have open lines of communication with referring GPs, with referring gynecologists especially, to discuss cases. And if there's any doubt that this is something that won't be of benefit, then that is something we discuss. And we have a really good open relationship with them to make sure at the end of the day we're doing the correct procedure for the correct patient to give them the maximum benefit. When I started my training in radiology, what really got me excited about the work that I do was the interventional part of it. And although I trained as a general radiologist and went into practice, there was always that nagging feeling that I should be doing more, and interventional radiology was my calling. So after a few years of doing other radiology, I decided to go and subspecialize in interventional radiology. I spent a year in Ottawa in Canada pursuing my passion and my interest in interventional radiology, and after that year got more stuck in doing procedures and cases, and I find that very rewarding. The great thing about interventional radiology is that you see your success. You see patients getting better, you actually get that feedback, and really that's what makes it so exciting for me. I get to use my skills as a radiologist, plus I get to use my skills doing things to bring the greatest benefit for my patients. So interventional radiology is a vast field, growing almost exponentially. My main focus of interest is vascular intervention, but I also do the non-vascular intervention. So we do lots of image-guided procedures, getting samples of tissue for patients that need a diagnosis, where it would have been a huge surgical procedure, may have taken 6-7 hours to get this. We can do it with the patient walking in and walking out. I also do lots of ports, which are devices that we implant for patients requiring chemotherapy. We do this on an outpatient basis. Patients literally come in, get the procedure done, and literally walk out. And we've had amazing success. Patients are extremely happy. But on top of that, we do the fibroid embolizations. We offer cancer treatments where we put in chemotherapy directly into tumors, for instance, into the liver. And often we'll stop bleeding where other people aren't able to, or the patients are just too sick to have an operation.